Welcome to the Deep Dive, the show that extracts the most essential knowledge and insight from a stack of serious sources, giving you the shortcut to being truly well-informed.
Today, we're digging into a deep and really critical subject, the intersection of gender, body image, access, and, well, profound institutional inequity in healthcare.
And we're moving far beyond the simple idea of just individual health choices, right?
Oh, absolutely. We're looking at the big picture.
Our sources today are extensive sociological texts and public health research, and they guide us in examining the structural barriers, the historical forces, and the entrenched societal norms that, fundamentally determine who gets quality care.
And who enjoys bodily autonomy and ultimately who lives longer. Our mission is to understand how these systems, which are often built on these really outdated binary assumptions, create measurable health disparities.
And frequently deadly disparities, as we'll see.
Yes, and to really begin this deep dive, we have to immediately disrupt the traditional rigid concepts of sex versus gender.
Okay, so let's define those terms right up front.
Right. So sex refers to the biological attributes, chromosomes, hormones, anatomy. Gender is, well, it's the social, cultural, and personal identity.
And in medicine, those two things are often just smashed together.
Violently compressed is the term one of our sources used, and that compression is what makes the story of Freddie so compelling.
So Freddie is a transgender man who chose to pursue biological parenthood.
Exactly. Freddie had transitioned from female to male earlier in life, aligning his body and identity, but then he decided he wanted to carry a baby.
So he had to reverse some of those measures.
He had to stop testosterone treatments, for example, but all while maintaining his male gender identity.
Which really puts the entire institutional framework of, say, obstetrics and prenatal care into sharp relief.
It does. I mean, how do healthcare professionals navigate a situation where the patient's gender identity is male, but the biological functions for pregnancy are, traditionally and exclusively defined in their systems as female?
It forces a confrontation, doesn't it?
It really does. It exposes just how rigid our healthcare systems are. Their protocols, their forms, their research, even the physical spaces were all built around this strict binary understanding of who we are.
So Freddie's journey isn't just one person's story.
No, it's a structural critique of medicine itself.
Okay, let's unpack the core concepts that structure this critique. We'll need a few key sociological ideas to frame this. First up, the concept of medicalization.
Medicalization is the process of redefining normal life aspects, things like aging or stress, childbirth, as deviant conditions that require some sort of medical attention.
So what's the implication of that? What does that actually do?
Well, it's a fundamental power shift. It transfers authority and control over these parts of life from the individual or the community into the hands of the medical establishment. We'll see how this specifically affects women's reproductive lives.
Okay. Next up, we have the sick role.
Right, the sick role. It's a concept from sociologist Talcott Parsons, and it outlines the expected behaviors for people who are sick and the people who care for them. Sort of a temporary social role.
With rights and responsibilities.
Exactly. You get certain rights, like being exempt from your normal duties, but you also have responsibilities, like trying to get better and seeking out competent medical care.
And how do gender norms complicate this?
Oh, they drastically influence how people adopt it, and more importantly, how doctors and nurses receive them. If society expects men to be stoic, they might delay getting care.
Violating their responsibility in the sick role.
Yes. And if society expects women to be, say, inherently emotional, their legitimate physical symptoms might just be dismissed as emotional reactions.
Then there's a term that's rooted in some pretty dark history: eugenics.
Eugenics is the belief in, or the practice of, improving the human species by encouraging reproduction among those deemed to have desirable traits.
Often defined by race, intelligence, or ability.
And actively discouraging or just outright preventing reproduction among those deemed undesirable.
And this wasn't some fringe idea in the past, was it?
Not at all. It was codified in law. Historically, eugenics gave the justification for forced sterilization, for racist policies.
Yeah.
It's crucial because we're going to show that its legacy and some of its mechanisms persist today.
Okay. And finally, let's just quickly touch on the social determinants of health, or SDOH.
Right. SDOH covers all the non-medical factors, the environmental, economic, and social conditions where people live and work. We're talking about income, education, housing, all the structural stuff that determines the vast majority of our health.
So it's not just about your personal choices.
Not even close. You can't really discuss health and equity without centering SDOH.
All right, let's start with a foundational observation from our sources that really undermines this idea of equal health outcomes. It's that while women, on average, live longer than men,
They experience higher rates of ill health or morbidity throughout their lifetimes.
so they may live longer, but they often live sicker.
And that phenomenon strongly suggests that gender discrimination, societal expectations, and just plain institutional inequity are contributing to this. That longevity advantage for women often masks a serious quality of life deficit.
Which brings us right back to the sick role. How does that actually play out differently for men and women when they're trying to get treatment?
Well, for men, the social pressure is often to be stoic and strong, right? And this is linked to their lower life expectancy. They're just less likely to seek preventative care or admit to symptoms early.
So when they finally do show up at the doctor's office, the illness is often more advanced.
Exactly. And the data linking men's lower life expectancy to higher rates of suicide, homicide, road injuries, that all reflects a sort of failure to prioritize self-care or mental health support.
And for women, the sources point to kind of the opposite problem. They're often overanalyzed maybe, but undertreated. We mentioned that doctors might dismiss their symptoms as emotional. How deep does that bias run?
It runs incredibly deep. It affects everything from cardiac care to pain management. For instance, a woman showing up with symptoms of a heart attack, which can look different than in men, is often diagnosed later because her anxiety or stress is seen first before her cardiac risk.
So the provider subconsciously fits her into that hysterical or emotional frame.
And it undermines her credibility about her own body. That's a direct consequence of institutionalized gender bias.
Wow, that's a powerful indictment of the system. But we can trace the philosophical root of this bias back centuries, can't we? To the creation of the so-called normative body.
Yes, absolutely. The historical standard that really set this whole course is Leonardo da Vinci's Vitruvian Man from the late 1400s.
Which was intended as a study of proportion, but it became something else entirely.
It became, over centuries, the societal and scientific representation of the healthy, standard, normative human body.
So this white European male figure became the default setting for humanity.
Precisely. It cemented the idea that males are the universal baseline for human physiology. And this, subtly but powerfully, defined anyone who doesn't look like the Vitruvian, man, women, people of color, non-binary people, as a deviation from the norm.
This is more than just a historical curiosity, though. What does that ancient artistic standard mean for, say, modern patient safety?
This is where it gets really, really dangerous. This narrow, male-centric definition translates directly into life-threatening standards in medical research and public safety design, even today.
It dictates everything from drug dosage to equipment size.
Everything. So let's look at the real-world consequences of underrepresentation. We can start with the massive failures in clinical trials.
Okay.
So a 2022 study we consulted confirmed that racial, ethnic, and gender minority populations are still significantly underrepresented in clinical research.
So even though there's been some progress, including white women.
Right, mostly due to legislative pushback. There's been distressingly little progress in increasing participation of racial and ethnic minorities over the last 3 decades.
So what's the tangible impact of that? Why does a lack of diversity in a trial matter so much to you and me?
Well, if your sample population is mostly male and white, the results on how a drug works and its side effects are skewed. Drug dosages, for example, are often initially calculated based on the average male body.
So a woman who has a different metabolism might get a dose that's way too high.
Or too low to be effective. It leads to more severe side effects. The same applies to racial groups with unique genetic factors. It basically means the standard of care, the recommended dose, is based on someone who isn't you.
And this design failure extends way beyond just medicine. The sources cite some specific, almost catastrophic examples in public safety design, starting with military gear.
Protective equipment, so uniforms, body armor, flight gear. It was traditionally built exclusively for a male physique. When women began serving in combat roles, the consequences were severe. Ill-fitting body armor restricted their movement, caused injury.
And it failed to cover vital organs. I remember the source material included a pretty horrifying detail about that.
Yes. The chilling fact noted by one researcher was that ill-fitting armor gave snipers a clean shot at vulnerable areas because the plates just didn't conform to the female anatomy.
So a structural failure in design leads directly to a fatal vulnerability.
Purely because of the assumption of a male standard body as the default.
And we see that same assumption playing out in civilian life, specifically in vehicle safety.
This is a classic example of a dangerous historical lag. Crash test dummies often still represent male body standards, sometimes dating all the way back to the 1970s.
So for decades, the standard for testing assumed a male occupant's size and spine.
Yes, and the data shows the deadly consequences of this. Absolutely devastating. Data on car accidents shows that a female occupant has a 73% greater chance of being injured in a frontal crash than a male.
73%.
And what's more, female drivers and front passengers are 17% more likely to be killed in a crash. The whole safety system, the airbag, the seatbelt geometry, it was optimized for a body that wasn't theirs.
So whether you're in a military combat zone or just commuting to work, if you're a woman, your protective gear is inherently less effective because you were excluded from the design standard.
It's institutional inequity made tangible in steel and plastic.
Let's transition to the gendered pursuit of healthcare around mental health. Our sources note women are more likely to experience things like eating disorders, anxiety, and depression. And we also see a disparity in suicide rates.
Right. Women are 1.5 times more likely to attempt suicide than men. However, men are statistically more likely to die by suicide.
Which reflects a difference in means and intent.
But it underscores that both genders are facing acute mental health crises, just shaped by different social pressures.
And the sources link this directly to environments with higher gender inequity.
That's the key. When women face poor living conditions, discrimination, or violence, their risk for mental health problems goes up significantly, and it becomes this vicious cycle. Poor mental health makes it harder to advocate for yourself, which feeds right back into having your physical symptoms dismissed as emotional, which then discourages you from seeking help at all.
Now let's talk about populations that completely defy that binary framework of the normative body. Intersex and transgender healthcare. We should probably start by defining what it means to be intersex.
Okay. Intersex describes people whose biology includes both male and female attributes, so maybe ambiguous genitalia or different chromosomal patterns that don't fit the typical XX or XY.
And this is a natural human variation.
A completely natural variation occurring in roughly 1 to 2% of the population that's comparable to the number of people born with red hair.
But when an intersex child is born, there's this immense societal pressure to assign a binary gender male or female, which often leads to surgery, right?
Yes, that practice became really common in the 1950s. Doctors and families, trying to minimize what they saw as social stigma, would assign a gender and then perform irreversible surgery to construct normative genitalia.
What were the risks of those early forced assignments?
The risks were profound. Patients often had to go through continued surgeries, hormone treatments. They endured a lot of confusion, shame, and trauma.
And critically, the assignment didn't always stick.
That's the tragic part. Studies show that up to 50% of people who underwent that early surgery may later experience gender dysphoria, a conflict between the gender they were assigned and their internal sense of identity. It's a brutal failure of trying to force nature into a social box.
The medical community has responded to this, though, by changing the language. They now use the term disorder of sexual development, or DSD.
Right, and they recommend against older negative terms like hermaphrodite. And the goal now, really championed by activist groups, is non-intervention. Meaning you delay any of these potentially harmful surgeries until the person is old enough to actually participate in the decision. It's a move toward patient autonomy over surgical conformity.
Okay, so we've established that institutional gender bias affects who gets studied and how they're treated individually. Now let's zoom out and see how we measure this on a population level, using 3 key global benchmarks.
Right. Mortality rate, life expectancy, and infant mortality rate.
These are basically sociological proxies for a society's overall health and equity.
Exactly. The mortality rate is the annual death rate per 1,000 people. Life expectancy is the average lifespan. And infant mortality rate, or IMR, measures infant deaths per 1,000 live births before their first birthday.
Let's focus on the U.S. infant mortality rate because the U.S. is a real outlier here among developed nations.
Yeah.
Our sources say in 2020, the rate was 5.4 deaths per 1,000 live births.
Which ranked us 50th globally.
50th.
50th,
Yeah.
far behind countries like Iceland, which has the lowest rate at 1.54. And even if you account for different ways countries measure these things, that disparity is a damning reflection on the U.S. healthcare system.
And the data strongly links IMR to global gender equality.
Deeply. High infant mortality is almost always associated with regions that have profound gender discrimination. Researchers conclude that to curtail child mortality, you have to prioritize women's rights and autonomy.
So access to education, economic resources.
Control over their own bodies. When you improve the rights of women, you fundamentally increase children's survival rates.
Turning to life expectancy in the U.S., we've seen some alarming trends recently.
Yeah, even before COVID, life expectancy was declining, mostly due to drug-related deaths. The pandemic just accelerated that. The gender gap is still there, though. 81.65 years for females versus 76.61 for males in 2020.
And that 5-year gap for men is tied to those social factors we discussed.
Riskier behaviors, delaying care, higher rates of violent death. But there is a positive story here in what the sources call the gender equality connection.
Okay, tell me about that connection.
Globally, research shows that countries with higher educational and workplace gender parity, so where women and men have more equal footing, see increased life expectancy for both men and women.
And lower maternal mortality rates.
Right. It proves that equality isn't a zero-sum game. When you increase systemic fairness, the health of the entire population improves.
This transitions us perfectly into the most crucial structural concept, the one that explains why these numbers are so different. The social determinants of health, SDOH.
Right, the SDOH. These are all the factors beyond biology, so the environmental, economic, and personal factors that influence your health status. Income, transportation, education, stress.
Your zip code is more important than your genetic code.
That's a good way to put it. Genetics loads the gun, but environment pulls the trigger. These structural factors determine how long and how well you live.
And the sources provide some genuinely staggering data on the geographic and economic disparities in the U.S. based on these factors. Let's start with life expectancy variation just between U.S. states.
In 2020, Hawaii had the highest life expectancy at 80.7 years. Now compare that to Mississippi, which had the lowest at 71.9 years.
That's almost a 9-year difference.
A 9-year difference in expected lifespan, dictated purely by where you happen to be born. And generally, states in the southern U.S. show lower life expectancies, which reflects historical underinvestment and persistent poverty.
That 9-year gap is a massive policy failure. But the financial gap, the one linking wealth to longevity, is even more profound.
It's the most brutal data point we have. A 2016 study found the gap in life expectancy between the richest 1% and the poorest 1% of individuals was 14.6 years.
A decade and a half.
A decade and a half of life. If you're born in the bottom 1%, you could miss your entire retirement, miss knowing your grandchildren. It's staggering.
So let's unpack the mechanisms that create that chasm. It's not just about having more money for medicine, is it?
No, it's a compounding array of benefits. Wealth allows for proactive, preventative care, access to specialists without waiting for months, better nutrition,
The lower stress load.
a far lower environmental stress load. High-income earners have more control over their jobs, less exposure to toxins. They live in safer, quieter neighborhoods. They have time to exercise. Poverty, on the other hand, creates chronic, inescapable stress, which is a powerful silent killer.
And the sources confirm that education plays a similarly huge role here.
Yes. People with college and graduate degrees can expect to live over 10 years longer than those without a high school education. And again, the diploma itself isn't magic. It's the correlation between education, higher paying jobs, better benefits, and the ability to live in healthier neighborhoods.
Which brings us back to poverty and gender. When you start with a structural disadvantage based on gender and then layer poverty on top, these factors get exponentially worse.
Right. Women are statistically more likely than men to live in poverty 11% versus 8% in 2019. And for families, it's drastically worse. Children in unmarried female-headed households were living in poverty at 5 times the rate of children in married couple families.
So women and children are disproportionately bearing the burden of economic vulnerability.
Absolutely.
Let's detail the specific environmental and safety factors linked to poverty that the sources highlight, starting with something as basic as food.
Impoverished neighborhoods often become food deserts. They're defined by the lack of easy access to full-service grocery stores with healthy, affordable food.
The example from Portland, Oregon was a perfect illustration.
It was. Specific neighborhoods where residents have to travel over a mile just to get fresh groceries, often relying on public transit or walking. If you're elderly or disabled or worried about safety, those healthy options might as well be on another planet.
Which leaves you with corner stores selling highly processed, nutrient-poor foods.
Exactly. And beyond food, housing quality is another major factor. People in poverty are significantly more likely to be exposed to high levels of toxins, rodents, and mold.
leading to chronic respiratory issues, allergies.
And psychological stress.
Yeah.
And then you combine that with a lack of access to clean water, and the picture gets even darker.
The sources mention water inequity in the U.S., and it is a truly shocking failure of infrastructure.
It is. It's a profound moral failure that in a nation like this, 1.1 million individuals lack a piped water connection entirely. This means contaminated water and poor sanitation are constant threats, leading to severe chronic illness from lead, arsenic, parasitic worms.
It's the absolute bedrock of public health.
And its absence creates this immense life-shortening disparity.
Finally, we have to factor in violence and health. The source material links poverty and discrimination directly to disproportionate exposure to violence.
Women in poverty and women of color are disproportionately affected by domestic violence. And when we look at the transgender community, the vulnerability is just compounded by that intersection of poverty and discrimination.
How acute is that risk for transgender individuals?
Well, transgender people are more than double the national average for poverty. And a 2015 survey found that over a third, 35%, experienced physical violence by an intimate partner. That's compared to 30% of the general U.S. population.
So when socioeconomic instability intersects with identity-based discrimination,
You get a perfect storm of negative health and safety outcomes.
and all these barriers continue right up to the moment someone tries to get care. We noted that women are more likely than men to delay health care due to cost 26% versus 19%.
And that delay is made worse by the unequal experience of seeking care. Our sources show women are more likely to report that a provider has dismissed their concerns, 21% versus 12%.
And worse, that a provider didn't believe they were telling the truth.
10% of women reported that compared to 7% of men. This institutionalized sexism leads to poor communication, delayed diagnoses, and ultimately poorer life outcomes.
Let's transition our focus fully to mental health now, specifically the incidence or morbidity of mental health issues.
Right. The heightened life stressors that come with systemic discrimination are clearly reflected in these statistics. The sources emphasize that sexual minorities of color face these intersecting disadvantages, racial bias, gender nonconformity, socioeconomic instability that all pile up.
Leading to significantly poorer mental health outcomes.
Chronic stress, anxiety, depression. These groups are navigating environments that are constantly hostile, and that takes an immense toll.
We also have timely data on COVID-19's gendered impact on mental health. The pandemic was not an equal opportunity psychological burden.
Not at all. It disproportionately impacted women, partly because they make up the majority of the workforce in those essential high-risk fields like nursing, education, social services.
So you have the professional risk combined with increased domestic and childcare duties during lockdown.
Exactly. It was a dual burden. And this resulted in a measured spike in increased depression, psychological distress, and critically, a big increase in substance use to manage those issues.
And the sources also noted the rise in interpersonal and domestic violence during lockdowns.
Yes, and that exposure to violence creates this considerable comorbidity with post-traumatic stress, anxiety, and other long-term mental health problems. It's like an invisible health crisis within the pandemic itself.
This often ties back into anxieties about body image and idealization that permeate our society, right? This constant stream of harmful gender-normative ideals through media.
The media ideal is just relentless and often impossible. For men, it's still about being muscular, tall, stoic. For women, it emphasizes extreme thinness, large breasts, narrow waists, youth.
Sociologist Jean Kilbourne's Killing Us Softly documentary has tracked this for decades.
Since the late 1970s, it shows how consistently damaging these expectations have been. And these ideals aren't just cosmetic. They create psychological pressure that leads to dangerous health behaviors.
And the sources reveal a body image crisis that is particularly acute in the transgender community.
That finding is critical because it forces us to see eating disorders not just as a vanity issue, but as a crisis of identity and control. Research finds that transgender students are over 4 times more likely to self-report an eating disorder diagnosis compared with cisgender heterosexual women.
4 times. Why such a high rate? What's the mechanism there?
Well, clinicians speculate that this behavior often starts before puberty as a desperate attempt to control the development of secondary sexual characteristics, body changes that don't align with their internal gender identity.
So restricting food, for example, could be an attempt to stave off breast development.
Or to achieve a more androgynous or masculine frame. It's a painful coping mechanism against profound gender dysphoria.
To understand the scope of this for the general population, we should probably quickly define the 3 major eating disorders.
Okay. First is binge eating disorder. That's characterized by recurrent episodes where the person feels a loss of control and distress over their eating, but without the purging behaviors.
And then there's bulimia nervosa.
Right. Bulimia is characterized by binge eating, followed by compensatory behaviors like purging self-induced vomiting, or laxative misuse, or fasting, or excessive exercise. People with bulimia often maintain a normal or overweight body but have an intense fear of gaining weight.
And finally, the most deadly of all psychiatric disorders, anorexia nervosa.
Anorexia is characterized by a significant and persistent reduction in food intake, leading to an extremely low body weight. It involves this relentless, often irrational pursuit of thinness and a severe distortion of body image.
The body is essentially starved of nutrients.
Yes, and it can begin to fail, leading to organ damage and, tragically, death.
The data on who seeks treatment for these disorders reveals a really powerful, counterintuitive finding. The stereotype is that it's primarily young women.
And the data partially supports that. Females are more likely to seek treatment for bulimia and binge eating disorder. But here's the paradox. Males are more likely to seek treatment for anorexia nervosa.
Wow, that completely overturns the stereotype. What does that tell us?
It suggests a couple of things. First, that while the public conversation centers on young women, men are significantly suffering, particularly from anorexia, which might be tied to masculine ideals of control or extreme fitness.
And second,
it suggests that the stereotype itself might be preventing men from seeking help for bulimia or binge eating, disorders that are maybe perceived as more feminine. It just highlights the need for more inclusive screening and destigmatization for everyone.
and all of these issues are compounded by weight stigma.
Or weight bias, weightism. It's societal degradation through negative attitudes and prejudice based purely on a person's body weight.
Rooted in stereotypes that people in larger bodies are lazy or lack willpower.
Yes, and it fails to acknowledge the complex biological and socioeconomic factors at play. This stigma leads to overt discrimination and is a risk factor for a range of emotional and psychological consequences for all genders.
But the findings on gender bias here are inconsistent.
That inconsistency is telling. Some studies suggest men are equally targeted, especially in employment. Others report that women experience more intense stigma, especially when it's tied to that cultural ideal of thinness as a core part of feminine beauty.
And with obesity rates rising, this is an ever-increasing public health issue.
The stigma itself often prevents people from seeking help or trusting medical advice.
So now we circle back to that concept of institutionalized sexism in medical framing, medicalization. Critics argue this is a primary driver of institutionalized sexism.
Right, because it redefines normal life events as deviant, requiring medical intervention. And this transfers power over basic biological function from the individual to the institution.
We saw the extreme example with intersex individuals.
Natural variations being medicalized through unnecessary surgery, but women's reproductive lives are arguably the most medicalized sphere of human existence. The sources detail the medicalization of menstruation, PMS, pregnancy, childbirth, menopause.
All natural, cyclical processes that have been framed as conditions needing clinical management.
And this framing comes from a deep societal discomfort. Let's just look at menstruation. Society uses blue liquid in period product ads instead of a realistic red liquid.
And when a 2017 Australian commercial did use realistic blood red liquid, people complained.
The complaints were fascinating, from bad taste to humiliation of women by publicizing a private matter. That reaction illustrates a deep societal taboo. It perpetuates the idea that periods are inherently deviant or dirty, which then necessitates a clean, clinical, medical framing.
It's culture driving medicalization and medicalization driving markets.
Precisely. And the childbirth controversy is a massive example of this.
In the mid-1900s, medicine made huge strides that reduced mortality.
Antibiotics, hygiene, better surgical practices, they were lifesavers. But in recent decades, many women have started pushing back against what they see as the over-medicalization of a healthy, natural process.
And this pushback is supported by research, isn't it?
It is. Research has found that non-medical interventions are incredibly effective.
Right.
Social support from friends, family, or a partner can relieve pain and anxiety during birth as effectively as some medical support.
And women with supportive partners needed fewer interventions.
Fewer epidurals, fewer surgical assists, and they had lower rates of postpartum depression.
Yet, formal medical settings in the U.S. still often prioritize interventions, leading to high rates of C-sections and induced labor.
Which is often driven by institutional efficiency and legal liability, not always patient necessity. The system is just optimized for medical intervention.
And then there's menopause.
Menopause is simply when the body stops menstruating. It's a natural transition, but societally, it's often viewed through a lens of decline or deficiency, a health crisis that requires medical intrusion, replacement hormones.
Because it signals a move away from the traditional feminine reproductive role.
Exactly. Whereas men's life transitions, like andropause or just aging, aren't typically viewed as requiring that same intensive level of medical management.
Beyond this framing, there are massive structural barriers to just getting care in the first place. Let's look at unequal access to healthcare.
Cost is the primary barrier for everyone in the U.S., but it disproportionately affects women. As we noted, women are more likely to report delaying care due to costs.
And that financial barrier is compounded by the rising cost of employer-sponsored coverage.
That model is becoming untenable. The source material shows family premiums for employer coverage jumped 47% in the last decade alone.
Far outpacing both wage growth and inflation.
Right. So even with good insurance, deductibles and copays cause chronic financial stress, leading people to ration or delay necessary medical care.
And if you're uninsured, the consequences are deadly.
Lack of insurance is linked to poor health outcomes because people delay preventative care. For example, uninsured Americans are significantly more likely to be diagnosed with advanced stage cancer when treatment is far more invasive and less likely to work.
A delay forced by financial constraint.
It's a direct mechanism of systemic failure leading to death.
And this lack of insurance is highly linked to racial gaps in coverage.
Yes, people of color are significantly less likely to have health insurance. American Indian, Alaska Natives, and Hispanic populations are the most likely to be uninsured. This is where poverty, employment instability, and systemic racism all collide.
And specifically for the transgender community, there are unique insurance barriers.
They face financial barriers due to higher unemployment, leading to lower coverage rates. But even when they are insured, they report these unique bureaucratic issues.
Like
Difficulty changing names on accounts, being denied coverage for services considered gender-specific, like pap smears or prostate exams, because their current gender marker doesn't align with the procedure's typical patient demographic in the system.
So the system itself fails to adapt to their reality.
That's the crux of it.
Okay, this section addresses the most high-stakes health issues, bodily autonomy and governmental control. For some women, regulating pregnancy isn't a political choice. It's a matter of life and death.
This cannot be overstated. The sources cite specific medical situations, women undergoing active cancer treatment, those who've had organ transplants, where managing or preventing pregnancy is absolutely crucial to their own survival.
The data on transplant recipients is terrifyingly clear about the stakes.
A study of pregnancies in pancreas and kidney transplant recipients found that adverse fetal and graft outcomes were seen in 100% of unplanned pregnancies.
100%.
Compared to only 10% in planned pregnancies where the patient's health was optimized and risks were managed. In these scenarios, the ability to prevent or end a pregnancy is essential medical management. It's not optional.
To understand the historical context of this control, we have to revisit the legacy of eugenics.
Right. Eugenics was this effort to improve the human race, but that effort was rooted entirely in the biases of the white male researchers and policymakers of the time. It targeted race, intelligence, ability, mental health.
And the sources show the most brutal method of implementation in the U.S. was forced sterilization.
This is a devastating chapter of American history. Over 60,000 people were sterilized across 32 states in the early to mid-1900s. The practice targeted people with little education, poor people, people of color, and those with disabilities.
It was a racist, ableist legacy supported by politicians and doctors.
And it isn't just a historical anecdote. The sources confirm this violence continues.
How so?
Tragically, forced or coerced sterilization is still imposed today, particularly on disabled women and women of color. The sources specifically note that women in California prisons were forcibly sterilized as recently as 2010.
And it affects the transgender community globally.
Yes. As of 2017, 20 countries still require sterilization for trans people to get legal gender recognition. It makes the denial of bodily integrity a bureaucratic requirement.
The discussion of control leads directly to the societal battle over abortion rights. Historically, this was more of a morality issue than a criminal one.
And that control shifted to formalized, white male-run medicine in the early 1900s. The critical modern legal framework began with Roe v. Wade in 1973, which affirmed a constitutional right to privacy.
But the reversal in June 2022 removed that federal protection, leaving the decision to individual states.
And this created this fractured, messy societal issue around the rights of the pregnant person versus the rights of the state.
And the consequences of restriction are immediate and measurable, constituting what our sources explicitly term governmental violence.
There's a clear, consistent correlation in the data. States with the most restrictive measures on pregnancy termination often have legislatures with a white male majority.
And those same states also show the poorest structural health outcomes for women and children across the board.
Yes, let's detail that because it's a profound connection. These highly restrictive states consistently show the highest infant mortality rates and the highest maternal mortality rates.
They also have the highest rates of children in poverty.
And the most restrictive healthcare supports and family leave policies. The political restriction of personal rights directly correlates with poor public health indicators for the entire population.
Which suggests the stated priority of protecting life is undermined by a lack of support for that life after birth.
It certainly raises that question, and the sources provide a terrifying example of how legal fear creates delays in care.
Tell me.
In October 2022, a physician concerned about legal action in her home state had a patient with dangerously high blood pressure endure a 6-hour ambulance ride to North Carolina to end a non-viable pregnancy.
A 6-hour ambulance ride.
A medically unnecessary and life-threatening delay forced by the chilling effect of legal threats.
This systemic inequity is amplified when we apply the concept of intersectionality, the inequalities produced by intertwined statuses, which brings us to the urgent Black maternal mortality crisis.
The data here is just staggering. In 2020, the maternal mortality rate for non-Hispanic Black women was 55.3 deaths per 100,000 live births. That is 2.9 times the rate for non-Hispanic white women.
2.9 times.
It is.
This crisis extends far beyond the delivery room.
Oh, yes. Deaths occurring up to 1 year after birth were 3.5 times more likely among Black women than white women. The leading cause of these late deaths was postpartum cardiomyopathy.
And Black women had a 6 times higher risk for that specific, often treatable condition.
Right. So the implication is that this is not a crisis of biology. It's a crisis of institutional racism and care. It is a failure to listen, to diagnose, and to provide the necessary follow-up for conditions like preeclampsia and cardiomyopathy.
Finally, we must touch on violence through genital modification, starting with female genital mutilation, FGM.
Right, also known as female circumcision or infibulation. FGM involves removing all or part of the clitoris and sometimes the labia, often without anesthesia for non-medical cultural reasons.
Things like prioritizing male sexual needs or ensuring a girl's virginity.
Yes. It occurs in about 92 countries, and the procedure causes severe adverse health consequences, including infection, chronic pain, and dangerous complications during childbirth.
So there's a structural consequence.
A direct one. Globally, high FGM prevalence countries also have high maternal mortality ratios. It's an intersectional violence where cultural practices create measurable negative health outcomes.
We contrast this with male circumcision, which removes the foreskin.
About a third of males globally are circumcised, but in the U.S. the rate is much higher, around 80% of adult males, generally due to cultural, religious, or paternal history.
And the sources note there's an ongoing debate about its medical necessity.
Yes, and whether it constitutes medically unnecessary surgery performed without the baby's consent. It brings the discussion right back to that fundamental issue of bodily integrity.
Okay, so given the systemic nature of these problems, from the Vitruvian Man to the maternal mortality crisis, what interventions for social change are highlighted in our source material?
Well, we can start with a resurgence of supportive care designed to combat the issues of medicalization, doulas, and midwives.
This is a direct patient-centered response to the over-medicalization of childbirth.
It is. So doulas are trained to provide non-medical, physical, and emotional support. They don't provide medical services, but they offer continuous comfort. Midwives, on the other hand, are licensed medical professionals, often nurses with master's degrees who can safely deliver babies.
And the disparity in their use in the U.S. is startling.
It really is. Only 8% of U.S. births are attended by midwives. Compare that to the UK, where it's over 2/3. Midwifery care is associated with positive birth experiences, fewer interventions, and it's a lower-cost alternative for low-risk pregnancies.
So they provide that crucial emotional and physical comfort that we know is so effective.
Exactly. Another key intervention is ensuring inclusive care through gender-affirming care.
This is where organizations like WP Path come in.
Right. The World Professional Association of Transgender Health. They provide global guidance to ensure informed medical care for trans and gender nonconforming people. It's essential for ensuring positive health outcomes in a population that's often denied basic dignity.
And for intersex people.
The Intersex Society of North America, or ISNA, is specifically devoted to ending the shame, secrecy, and unwanted, medically unnecessary genital surgeries on people born with anatomy that isn't standard male or female.
So gender-affirming care really covers the full spectrum.
Sexual health, reproductive health, hormones, mental health support, all with the patient's autonomy prioritized.
And to achieve true autonomy, we have to look at the legal and philosophical framework being championed by activists. Reproductive justice.
This is a crucial evolution beyond the narrow focus of pro-choice versus pro-life. The sister song Women of Color Reproductive Justice Collective defines this as the human right to maintain personal bodily autonomy.
Have children, not have children.
And, crucially, to parent the children we have in safe and sustainable communities.
So it expands the focus beyond just access to abortion to include all those social determinants of health we talked about.
Exactly. Reproductive justice acknowledges that a woman living in a food desert without paid family leave and facing medical bias does not truly have reproductive freedom, even if abortion is technically legal.
Moving back to the debate over genital modification, the final intervention discussed is the intact penis movement.
This refers to activist groups like Intact America that are striving to eliminate male circumcision on babies. They frame this discussion within the broader debate of bodily integrity and genital cutting.
Viewing it as medically unnecessary surgery carried out without consent.
Yes, in the name of culture, religion, or profit. They draw parallels to the legal views that prohibit FGM, arguing that consent must be the cornerstone of any permanent alteration of a baby's body.
This entire deep dive has been such a powerful look at how institutionalized biases, whether based on gender, race, or economic status, have these direct, measurable, and often tragic health consequences.
The structure is the illness.
That's a great way to put it.
The synthesis is abundantly clear. Institutionalized gender and racial inequities are not theoretical problems. They manifest in every single health benchmark we have, from underrepresentation in crash safety studies to the horrifying crisis of Black maternal mortality that is 2.9 times worse than for white women.
And when you trace the historical arc, it moves from a period where women regulated reproduction through folk knowledge to the rise of white male-dominated formalized medicine and the brutal era of eugenics.
All the way to the modern, complicated fight for reproductive justice and self-determination. And the data tells one consistent story globally and domestically.
Which is,
the states and countries that impose the most restrictive personal rights on people, especially women and marginalized populations, are the ones with the lowest life expectancies and the poorest infant and maternal mortality rates. Restriction and poor health are consistently correlated.
so since our sources clearly show that the states with the most political control over reproduction consistently have the worst outcomes for maternal and infant health, this raises a profound question for you to consider. What does the connection between political restriction and poor public health data tell us about the ultimate priorities or true purpose of state health policy?
Thank you for joining us on this essential deep dive into the structures that determine health.
We'll see you next time.